project we'll be presenting was developed and implemented by the Department of Health and Family Welfare in Kerala. And traditional and technical expertise was provided by a team of doctors from the UK, and it was all funded, or it was funded by the UK Department of International Development. My wife and I were part of the team, but the team was led and inspired by Professor Mala Rao, and she would really much have liked to have been here today, but she's currently in America, and so she wasn't able to come. So we've come in her place to try and present some of the findings from that project.
Excellent. So we're ready to go. So, okay. So excuse me putting my glasses so I can see. Right, okay. So the project that we will be describing is, as far as we are aware, one of the first attempts to provide universal health coverage through a new model of primary care delivery to a defined population in India. The goal of the project was to strengthen primary care in 3 health facilities in Trivandrum, covering a population base of 117,000. The principles of primary care, as described by Barbara Starfield and the WHO, which we've heard brilliantly described to us by Garth, were applied. And experience of working within a primary care-led healthcare system in the UK was used to inform the project development. In this presentation, we will share learning from our perspective, but we will also draw on the findings of a recent evaluation report which has been shared with the UK team but has not yet been published. The report was funded by the UK Department of International Development and carried out by an independent organisation, Access Health International, in collaboration with the Government of Kerala, and has therefore described outcomes and lessons learned from the perspective of an external evaluator. I know that everyone participating in this conference will be very much aware of the importance and significance of India's 12th five-year plan published in 2012. And as we've already heard much about this plan recommended universal health coverage as a strategy to address national health goals. The principles and goals of universal health coverage apply across a health system, and therefore many different interventions can be tested at different points within that system. Different models will, and in fact are, emerging depending on the focus of the intervention. For example, schemes to provide funding for specific interventions will support the goal of equitable access, but tend to have a secondary care focus, and I think we've heard a little bit about that earlier this morning. However, the unique feature of the project that we are describing is that it embraces the principle of addressing the wider determinants of health, while seeking to ensure equitable access to affordable, accountable, and appropriate health services. The focus of the project is the population, and the first point at which the population interfaces with the healthcare system. Community and existing primary care assets were harnessed and developed to strengthen promotive and preventive care, whilst at the same time ensuring provision of appropriate disease-focused services. So how did the project do this? Well, the main objectives are listed on this slide. As the project had a population focus, aiming for population outcomes, the implementation of guidelines to support consistent delivery of evidence-based care was an important aspect. In order to offer better and more systematic patient care and measure implementation and outcomes, there needs to be a system of data capture. Hence the objective to agree a minimum data set and design an IT system to collect and collate the data. This would not only allow for monitoring of implementation and outcomes across the study population, but it would also have the potential to support ongoing quality improvement through effective feedback and support for audit. An effective IT system would also have the potential to support call and recall systems for chronic disease management. Improvement of the infrastructure and agreement of an essential medicines list were also important objectives of the project. This would help to drive up quality and ensure provision of essential services at primary care level. An important focus was to discourage medicines of uncertain value and to encourage greater use of existing diagnostic services at the PHC. Finally, and most importantly, to involve community leaders to create local ownership of primary care services. As with any project that aims to produce sustainable change, identification and engagement with key stakeholders was an important aspect of the project, particularly the initial phase. Co-design of the model and collaborative working were consistent themes throughout all three stages of the project, with the aim of facilitating local ownership and ensuring appropriate, realistic interventions consistent with the working environment of the healthcare facilities. It was vital that this project wasn't something that the UK team came in and sort of directed and imposed on this. We were just facilitators to draw people together to help them develop their own ways of solving the solution of strengthening primary care in their health centres. Collaboration and multidisciplinary working was an important aspect of developing the local evidence-based guidelines, and training and capacity building for the health facility staff. So at all stages, it was a collaborative effort working across disciplines to draw people together to improve the quality of the services that they were delivering. Improving the infrastructure involved improving the buildings and buying equipment. However, and more importantly, it also involved strengthening the human resources available and the treatments available by ensuring continuous supplies of essential medicines. The timescales to achieve these objectives were short. Mala Rao was invited by the Government of Kerala to lead the development of the project proposal for submission to the Government of India in 2012. The project began in January 2014, and the UK provided expertise to the project between January and June of that year, and the project ended in December of that year. The evaluation by Access Health International and the Government of Kerala, funded by the UK Department of International Development, took place between February and April 2015, with the final report submitted in September of this year, although it has not yet been published. At this point, I'm going to hand over to Carl, who will describe some of the highlights and learning from the project.
Well, the three health centres that they selected were already striving to provide excellent services for their patients within the constraints which I'm sure you're all familiar with, heavy workload and limited resources. The medical officers were experienced and they were enthusiastic about the opportunities which the project offered to them. And they were committed to see it produce change in their working environment. And the staff at the health centres, under their leadership, caught something of that enthusiasm as well. And right from the beginning, it was seen as a group endeavour, something that the whole health centre was involved in, and not just something for the doctors to do. So collaboration was important within the health centre and also between the participating health centre teams, and also between the primary care doctors and the secondary care specialists as well. We visited the primary health centres many times, and all levels of staff, from the cleaners and ground staff through the lab staff, the pharmacists and nurses, they were all eager to share what they were doing, what their role was in providing care. And there were no shortage of ideas from all levels about how the service could be improved if they were given the chance. And as the teams met together, they began to share some of their practices, and that actually improved or led to significant changes for the service provided in all the health centres just by sharing their ideas together. I think if you can see in the slide, there's a waiting room. Two of the health centres had TVs, and they had plans to show patient education to people who are waiting. You often have to wait a long time in health centres to see the doctors, and they wanted to use health promotional DVDs and things like that to use that time profitably. And the one that didn't have it was keen then to take up that idea just because of talking to their colleagues. Similarly, there was kitchen gardens around 2 of the health centres, which had a wide variety of produce when we visited them. And again, another of the health centres lacked that. And so just by talking to their colleagues, they began to think about how best practice could be spread. So there was collaboration between the different teams throughout the project. There was collaboration between primary and secondary care, and that was right from the start. It was necessary to select a focus on 6 subjects, and who would decide those subjects? It was decided that it would be done by forum, and so the University of Trivandrum Medical College, organised such a meeting, and it drew on both specialist opinion and community opinion, and it met in 2013. And common conditions were ranked by everyone, and then they were voted on so that a consensus was reached. 2 related to maternal and child health, so there was antenatal care and immunisation. 2 were to do with the growing public health problem of non-communicable disease, that was diabetes and hypertension. And 2 were selected just because they were common problems which presented to the primary health centres, and where there was a belief that maybe more could be done at that level. And that was fever and depression. And depression was particularly important because working on that topic forced everyone out of their comfort zones and into new ways of thinking. Prior to the project in this area, mental illness was generally managed, if it was managed at all, by the secondary care services. And the primary healthcare teams felt unable to do more than just direct patients in that direction. So working with the UK team and also with excellent secondary care services, together they were able to come up with simple protocols for the diagnosis and the management of depression, empowering them to pick up more cases, giving them an incentive to do that, and equipping them to manage the simple, mild cases themselves. And that was the first time that something like that had been done in the context of the Kerala PHCs. Collaborating on implementing national protocols allowed education to flow in both directions. Specialist input was, of course, invaluable, but everyone was surprised to find how much teaching could flow from primary to secondary care also. A primary care perspective helped to keep the guidelines simple and closer to the realities of patients from all backgrounds. And the discussion really boosted the morale of the community doctors. They felt that their interventions were valued and appreciated. And the discussions extended beyond the guidelines into areas like the quality of referral letters, the clarity of follow-up requirements, and the feedback to the PHCs. Now, I myself vividly remember the work we did in my practice in computerisation in South Wales nearly 30 years ago. We were afraid that it would increase our workload and not benefit anyone, except perhaps the government, who were hungry for data. I also know that it was all worth it, that it turned out to be a good thing, both for individual patients and for the community at large, allowing much better auditing and planning. And so it was really exciting to be part of implementing an IT system in the Kerala scenario. And it was completely innovative. They hadn't done anything like this in the primary health centres in Kerala before. And they were starting from scratch. They had to identify a software company and get them to understand what it was that the state required. They had to wait while the IT people internalised that information and took it on board and produced a system which could deliver what they were looking for. Then they had to teach the medical staff and the clerical staff how to use the computers, and also they had to learn from their mistakes at every stage. Now, the company they chose, like many IT companies, was young and full of enthusiasm. They were bright and eager to learn. And they were energetic and positive. And they had that infectious belief that there is no problem that is impossible for a computer. All levels of staff learned together how to use the computer in theory and then in practice. One of the activities, simple activities, which we did during our time in Trivandrum was to do a study of the patient flows on a typical morning in one of the health centres. We observed the high workload, as was to be expected, but we also saw that all the patients were channeled through the doctors, even those who were just coming for more medication or for routine checkups and blood tests. Now, we discussed these findings with the team at the health facility, and we looked at this when they were introducing the IT system also. And we were able to discuss the potential of shifting some tasks to other members of the team, particularly the nurses. So they could see some patients in a pre-check area before they met with the doctor. And it was also seen that in future, repeat prescribing systems could be added into this so that a lot of workload would be shifted from the doctors, who could then give their time to actual clinical areas. Now we're able to move on.
I think this is a visual illustration of IT and how it can be difficult to implement.
They did just the next slide up is just a list of the essential medicines which had been agreed. So it was already agreed, and I'm sure this is common experience in India, it was already agreed what the essential medicines were, but the supply was erratic. So that one of the things which the project focused on was producing a system which ensured availability. So this was a big help to patients who didn't have to keep coming back to get their prescriptions, and raised their confidence in what the PHC could actually do for them. And it reduced frustration all around and tension in the health centre. And as they were discussing the essential medicines list, they also began to have productive discussion about medications which were not on that list and why they weren't there. Injectable paracetamol, for example, didn't find itself on the list. And even though in some of the centres it was commonly used, mainly, they said, due to patient demand. And this discussion highlighting, what's evidence-based and what isn't evidence-based, and sharing different practices between the health centres, different approaches, produced a commitment to reduce the use of injectable paracetamol and other non-evidence-based medications in all the PHCs. And they saw that that would release valuable nursing time for other activities which they would like to do, such as foot checks in diabetics. An innovative and inspiring aspect of the project was the involvement of the local self-government institutions. I think these are equivalent to panchayats in other areas of India. They're sort of locally elected local government for the area covered by the PHC. And the project took them into the health camp. It used them as partners with the doctors and with the health centres. And of course this is really great because they can act as an ambassador to the population for the PHC. And also they could go the other way. They could share the concerns of the community with the PHC staff, and they could work at practical solutions to help address these things. And of course as well, they could act as health promoters in the community for areas which were difficult for the PHC to reach, but which were so important. Things like alcohol abuse, domestic violence, smoking prevention, diet, physical activity, sanitation. And this was something we took away from the project because in the UK we're always looking at our own practice, and we were reflecting that we needed more partnerships like this, where practices and communities were working together to promote a healthy environment for everyone. Anna Soubry, who was our previous public health minister, commented on this particular aspect of the project when she visited it early on. At the end of the interim phase, we were able to think about the project as a UK team before we left and wonder about what had worked well from our perspective. And we directly observed the improved connections between the hospital clinicians and the primary care clinicians, and the increased respect which the secondary care doctors had for the people working at primary care level. And we had also seen how the multidisciplinary learning in group discussions was hugely welcomed. We'd seen also that the local self-government institutions embraced their role. They were really eager to take part in the project and to work with the PHCs. And perhaps for our perspective as well, it was great to see the teams within the primary health centres coming together and seeing their morale improved. And also, not only did they realise they were valued, but they also saw how much they could do, that they could do so much more for the health of their the community. Reflecting on these issues, we could see the potential for primary care centres to become more population focused and prevention orientated, rather than just reacting to the needs of the population presented on a particular day. And although prior to the project there'd been a recognition of different skills, of different roles within the team, during the project it had evolved into a team approach, both within the PHCs individually and also between the PHCs as they collaborated together, and to an extent between primary and secondary care. As we left, it was only such a short intervention, as we left it was clear that ongoing training and support would be needed to embed the new concepts if it was going to be a sustainable change. This was a massive shift in their thinking, in the work they could do. And we had concerns that much of the training would be lost under the pressure of everyday work, putting strain on the system, unless they had ongoing facilitated support. They'd find it difficult to sustain and really embed and develop the new ways of learning, of working.
Okay, I think we're about to have the IT back again. But just to finish, really, as we reflected on the findings that Carl had just said and what we felt had worked and lessons that were learnt, it was really interesting to read the as yet unpublished evaluation report and to find that they really confirmed our thoughts, really. They talked about staff turnover. Staff turnover was actually a big problem because there were quite frequent staff transfers. So the staff that were trained were then moved on. And of course it was difficult then for the new staff to be sort of orientated to the ideals of what the health centre were doing in the context of their busy work. So that led to a sort of, if you like, a leaking of what had happened with the project. And so that was one thing that we had, and they reported that while we were there, that they felt that would be difficult. Inevitably, there were struggles with the IT system, and we've just seen a demonstration that IT systems can be difficult, and this was a new thing for them. And it resulted really in inconsistent use and incomplete population data. However, we were actually happy with the fact that the project had introduced the concept, and that the teams, and it wasn't just the doctors, all the teams, because the nurses were involved in data entry, and they'd asked, while we were there, they asked for a data entry clerk because they could see that it would be quite difficult to enter all the fields on the patient registration that were being suggested. And so they knew that it was going to be a problem, but they were really keen to make it work. So we feel this was just a start, and the ongoing improvement in data entry will hopefully produce more and more robust data and give them a population feel, enable them to see what they were doing, the work that they were doing from a population basis. Now, the fact that there were no incentives for the staff to continue with the new ways of working is important to reflect on in terms of strengthening and delivering consistent primary care services. In the UK NHS, the use of incentives for good or for bad has consistently been shown to change clinician and practice behaviour and encourage delivery of the incentivised intervention. So to draw to a close, we'd just like to share some of the outcomes, the positive outcomes that were reported at 1 year on in the evaluation report. So there was evidence of increased public confidence in the PHCs, and this is actually a really important outcome because in Kerala particularly there's very high use of secondary care services, and I think the theme that we've been discussing, and we all know that it's a real problem, this whole thing about, you know, patient demand and they want the specialist, and where they've got choice they will often bypass. Now that makes it quite difficult then if you're trying to implement a population-based healthcare intervention showing population health outcomes, if you can't actually sort of, you know, keep, if you like, and follow your population. But there was evidence that by going through the route for sort of quality improvement so that the people will choose you, that this was actually beginning to have some sort of impact. There was evidence that the task shifting and the protocol implementation had actually continued, which was really encouraging for us because that was quite a new concept. And yet that when the evaluators went in a few months after we left, they were finding that that was still going on. And then the health centres were able to expand their services, and there was a feeling that they could do more for their patients, that some of the things that we were showing them diabetic foot examination, that was new for them, and they were taught that, and they had non-communicable disease clinics in the afternoons, and they were beginning to implement that. And one health centre actually extended its opening hours to 4 o'clock in the afternoon so that they could provide better services for their patients. For me as a public health doctor, to see this actually become a reality, we're working on this in Wales to make it become a reality in Wales, but to see that we were actually involved in something where this was perhaps a little first stage to make this happen in your country was really, really encouraging and has the potential to have huge population impact because as we were hearing, I think, from Mr. Desiraju, that actually we need to be working at community level as well to change behaviours and to work at the whole health system right from the community up, and there was evidence that this project was beginning to do that. So what about the potential for family medicine? Well, I hope that people are sitting there and after the morning's presentation as well thinking about universal health coverage. I think that we're all very much aware of the importance of family medicine in the universal health coverage movement. And we know, and we've heard actually, that the government is committed to strengthening and investing in primary care. Now, although the duration of the project was too short to demonstrate quantitative hard outcomes in terms of population health, the evaluation report states that it has an impact on the views of policymakers and field workers and made them realise this potential of primary care institutions to achieve universal health coverage in India. And that's a fantastic outcome, that people are beginning to look at this and they're beginning to say, yes, you know, family medicine and primary health care can help us achieve our national health goal of universal health coverage. From the perspective of the UK team, we felt that the project demonstrated the potential of a public health primary care partnership across 2 different cultures to promote shared learning and strengthen the population of primary care actually in both countries from the learning that we were able to take back into our own health system. However, a short defined input as this project can only result in limited outcomes. For more sustainable change and ongoing quality improvement, a more long-term relationship would be necessary. So to finish with words in the evaluation report, this pilot has provided a road ahead for others to follow. Are we ready to start the journey?